We have a patient with a painful and swollen right leg for 1 month. It's always essential to keep in mind that chronic pain and swelling, especially in a younger population, should raise red flags for something more sinister than just simple trauma or infection. Starting with the X-rays, we immediately notice a destructive lesion in the proximal tibia. There's a mix of both sclerotic and lucent areas, indicating both bone formation and destruction, a hallmark of aggressive pathology. Then we see the elevated periosteum, which forms what we know as Codman's triangle. This periosteal reaction is caused by the aggressive growth of the lesion, pushing the periosteum off the bone. It's a classic feature of osteosarcoma. Additionally, we can identify the presence of a soft tissue mass, another clue toward malignancy. There's also no clean demarcation between the healthy and diseased bone, hinting at the lesion's invasive nature. Switching to the CT scan, this image gives us even more clarity. We can see the lesion's permeative pattern more distinctly, with the destruction of the bone extending into the surrounding soft tissue. There's no clear border between the lesion and the bone marrow, which further solidifies our suspicion of an aggressive malignancy. This is not a benign process, and the presence of surrounding soft tissue involvement only makes it more concerning. There's no evidence of calcifications or matrix that would suggest a cartilaginous tumor like chondrosarcoma. Next up, the bone scan shows heightened uptake in the tibia, which confirms increased metabolic activity. What's crucial is that this lesion seems to be solitary within the skeleton, which is somewhat of a relief in terms of staging. The bone scan rules out multifocal disease, at least in the bones, so we're dealing with a single primary lesion here. Now, when we look at the lung CT, we find something equally alarming: small parenchymal nodules. These nodules, given the context of this aggressive bone lesion, are highly suspicious for metastatic disease. And with osteosarcoma, the lungs are unfortunately a very common site for metastasis. These findings begin to point more definitively toward our diagnosis. So what are we dealing with here? Let's break down the possible differential diagnoses. The aggressive bone destruction and periosteal reaction could also suggest Ewing's sarcoma, but this is less likely because Ewing's sarcoma often presents with an onion skin periosteal reaction, which we don't see here. Osteomyelitis could be a consideration, but the lack of systemic symptoms, like fever, along with the periosteal reaction, leans us away from infection and more toward malignancy. The most likely diagnosis, based on these findings, is osteosarcoma. It's one of the most common primary bone malignancies, especially in younger patients, and it frequently presents in the long bones near the knee, just like we see in this case. Osteosarcoma is notorious for causing aggressive bone destruction and periosteal reactions, like the Codman's triangle and the sunburst appearance that we noted earlier. Let's now take a step deeper into understanding osteosarcoma. It's one of the most common bone tumors, primarily affecting teenagers and young adults, typically between the ages of 10 and 15, with a slight male predilection. It usually arises de novo, meaning without any prior predisposing factors, although in older adults, it may arise in the setting of Paget's disease or after radiation exposure. In our case, we're dealing with a young adult, which fits well with the de novo occurrence of osteosarcoma. The tumor usually originates in the metaphyses of long bones, often around the knee or in the proximal humerus. One important feature to remember is that osteosarcoma can mimic benign conditions. Trauma may be in the history, and that can be a red herring, diverting attention from the more concerning features like persistent pain, despite rest, or pain that worsens at night. From an imaging perspective, osteosarcomas can be identified with some classic radiological signs. There's the destructive bone lesion, often showing mixed sclerosis and lysis. The malignant periosteal reactions, like the sunburst appearance or the Codman's triangle, are highly suggestive of the diagnosis. Sometimes you can also see an onion skin appearance with lamellated periosteal reaction, though this is more characteristic of Ewing's sarcoma. A soft tissue mass, as we saw in this case, is also common in osteosarcoma. Further evaluation with MRI is the next step, especially when you need to assess the extent of soft tissue involvement or determine the tumor's relationship to the joint and surrounding structures. MRI also helps delineate the intramedullary spread of the tumor and guides surgical planning. On MRI, osteosarcoma typically presents with low signal intensity on T1 weighted images and high signal intensity on T2 weighted and STIR sequences, with marked enhancement after contrast administration. One of the most critical components of managing osteosarcoma is assessing for lung metastases, which we've already identified in this case. Lung metastases occur in up to 20% of cases at the time of diagnosis. They're often subpleural and can cavitate, leading to complications like pneumothorax. Treatment typically involves a combination of chemotherapy and surgery. Preoperative chemotherapy is given to shrink the tumor and make resection easier. The goal of surgery is wide resection with clear margins to minimize recurrence. Post-operative chemotherapy is then administered to address any residual microscopic disease. Now, an important prognostic factor in osteosarcoma is the tumor's response to chemotherapy. If more than 90% of the tumor undergoes necrosis after neoadjuvant chemotherapy, the prognosis improves dramatically, with survival rates reaching up to 80 to 90%. However, if less than 90% necrosis is achieved, the prognosis is poor, with long-term survival rates falling below 15%. In this case, the patient will likely undergo further imaging, including MRI, to better define the local extent of the tumor and plan the surgical approach. After surgery, post-operative chemotherapy will be crucial to ensure any microscopic disease is treated. The presence of lung metastases makes this case more complicated, and depending on their size and distribution, surgical resection of the metastases might be considered. To summarize, we've worked through a complex case of osteosarcoma with typical imaging findings of aggressive bone destruction, a periosteal reaction with Codman's triangle, and soft tissue extension. The presence of pulmonary metastases highlights the importance of systemic chemotherapy, in addition to surgical resection of the primary tumor. Thanks for joining me on this journey through the radiological clues of osteosarcoma. If you enjoyed this breakdown, make sure to subscribe to Radiology Made Easy on YouTube, where we make complicated cases like this approachable and fun. Don't forget to drop a comment with your thoughts or any other cases you'd like us to explore.